heard the news that Mothers to Mothers had arrived in the country.
Yes.
What was that?
Yes, February was the launching of Mothers to Mothers, although we officially started in Ghana in October 2019.
Right.
I actually joined in October 2019. We had our initial consultations with stakeholders and with partners, and began our recruitment and training of our mentor mothers, who are the backbone of our program. So in February, as I'm sure you heard, that the British Airways executive director was here,
Yeah.
because
It was big news then.
It was big news, and there was a lot of plans of people trying to even create issues, because our program at the time was funded by British Airways through Comic Relief. But that program ran until June 30th, and we have new funding now. So February 2020 was the launch. It was the showcasing of Mothers to Mothers in Ghana, and it was a big event because Mothers to Mothers works in 10 countries. The other 9 countries are in Southern and Eastern Africa. So the first country in West Africa is Ghana, and which is typical. Ghana is the gateway to West Africa, we would like to believe. So Ghana is our first West African program,
So
out of the 10 countries.
but okay, so what do you do, Mothers to Mothers? These are very basic things that my viewers would like to know.
Yeah.
You launched Mothers to Mothers
Yes.
in February 2020.
Yes.
To do what?
So Mothers to Mothers is headquartered in Cape Town. It started in South Africa. It believes that a healthy generation starts with mothers. And in Ghana, we work with HIV positive and HIV negative pregnant women and breastfeeding women. We implement an integrated RMNCH model, which includes ECD components, and I know you're very interested in ECD, and also very recently we've included activities in adolescent health. So Mothers to Mothers, actually, it's a very unique NGO, because we work basically with HIV positive women who are our staff. So all our staff in our site are actually HIV positive women. And in Ghana, we work in Ashiaman Polyclinic, where we've trained 11 HIV positive young women, and in Atwa Government Hospital in Somenia, where we've trained 9. So we have a total of 20 HIV positive women whom we call mentor mothers. Mentor mothers who support other HIV positive pregnant women as they go and they embark on their journey on prevention of mother-to-child transmission.
Yvonne, we on live TV. You've told us about some of the women you work with,
Yes.
who are HIV positive.
Yes.
You are making this announcement public.
Yes.
Are you not concerned that these women will be stigmatized, and therefore probably these, you mentioned a polyclinic and so on, where they work, that once people begin to know that these are HIV positive persons, they will be stigmatized, they will be ostracized, and so on. Are you not concerned?
Not at all. It's the uniqueness of our model. It's a peer-based model. So our founder, Mitch Bessett, who started 20 years ago, exactly in October, actually discovered that HIV positive pregnant women who were on treatment actually would listen more to other HIV positive pregnant women. So he started the Mothers to Mothers movement, or NGO, with a focus on bringing other HIV positive mothers to support and do exactly what you're describing. Support them with positive living, ensure that they are not ostracized, ensure that they are not discriminated against, and ensure that they have access to the services that they need to remain healthy. So our mentor mothers are selected based on that criteria. And they know that this is the work that they're doing, and the work they do is actually to share their stories. You know, in Ghana, in the antiretroviral therapy field, we implement test and treat. So when a mother shows up at the antenatal clinic and she tests positive, she's immediately initiated in treatment. I have a different model. I call it test, Mothers to Mothers, treat. Test, mentor mother, treat. Because unless that psychosocial support is available to the newly diagnosed HIV positive pregnant woman from a woman who looks just like her, it is very difficult to achieve positive treatment outcomes. So our model is public. If you go online to www.m2m.org, it's very, very clear. We have HIV positive spokespersons. I can invite a few to your future shows, and they can speak publicly about the HIV status because they are living very positively.
What sort of feedback have they been given to you? Because I believe they work within a certain social context where even though they are the mental mothers, they also work within the larger health facility where persons still, and that's the reality, are not very comfortable with HIV/AIDS or people who are living with it.
So actually they are a very, our mental mothers are trained, they are empowered, they are capacitated to actually support the health system to deliver on its promise, to provide unstigmatized, health worker-friendly services. So having our mental mothers in the two sides actually strengthens that resolve. And I mean, it's not uncommon for someone to say, hey, I have this pregnant woman, she's newly diagnosed. I would love you to have a chat with her. And they look at her and they're like, you're lying, you cannot be positive. She says, I've been living positively for 20 years. I have 5 negative children. So the objective and the strength and the uniqueness of our model is the fact that by working in those facilities, actually, we begin to see declines in stigma. Because they normalize HIV/AIDS. They make it like any other illness. And the beauty with HIV in this era is the fact that before there was no treatment. But actually now, if you remain on your treatment and you adhere to your treatment, unsuppressed HIV-infected women can actually not transmit the virus. So the work that we do is also to support our mothers who are on treatment to achieve viral suppression. But they need somebody to hold their hand. And that person has to look like them. And that person should be able to walk their journey, talk their talk, and wear their shoes. And unless the person is HIV positive like them, they cannot. So for me, I think that is what I'm most proud of as a technical specialist and country lead for Mothers to Mothers. And over the last 20 years, we have, and these mothers are our staff. So when you go to my site, you will not find an advocacy coordinator. You find a mental mother. You will not find a TB coordinator or an RMCH coordinator. You find a mental mother. They go through rigorous training, 21 days of residential training. So they have not just the ability to live positively, but they also have the technical knowledge and they thoroughly understand the dynamics of living with HIV. So they are spokespersons, they are educators, they are teachers, they are pace setters. They lead the way against a stigma-free Ghana.
Are you in any way working, collaborating, whatever you call it, with the Ghana AIDS Commission?
Absolutely. Mr. Tuahine, the Director General, is one of our biggest funds. We work very closely with Dr. Nsiasari, who is the Presidential Advisor on Health. We work with Dr. Aboaje, who is the Director General for Ghana Health Services. We work with Dr. Eisiado, who is the NACP Program Manager. And now M2M is part of the country coordinating mechanism for the Global Fund. So we work very closely with the Global Fund principal recipients as well. I'm actually an alternate member of the CCM for women and children.
So from you've been operating since October. The launch was in February last year. Between then and now, what can you tell us of the picture before and the picture now?
Absolutely. Very excited to talk about this. So far, I mean, by the end of June, we have reached about 11,248 clients, about 5,000 mothers and about 5,650 children. And again, our work targets both HIV negative and HIV positive, because the first step in stopping transmission of HIV to the unborn child is to ensure that the mother doesn't get infected in the first place. So primary prevention is one of our key objectives. What has changed? A lot of game changes. I can speak to a number of things. One, maternal retention in care. So before we came, there was a lot of treatment defaulting because healthcare worker attitudes. I mean, if I come and I feel stigmatized, I will not come again. You can tell me all the benefits of staying on my medication, but if I don't feel supported in the health facility, I will not return. But when I come and I sit down, because our clients, when they come for their appointments for their refill, each time they come, they have a counseling session with our mentor mothers. Are you taking your medication? We actually do adherence assessments. Are you taking your medication? Are you skipping your medication? Have you felt any side effects? How are you feeling generally? Are you even coping with this pregnancy? Are you coping with this newborn child that is on your hand? So the maternal retention has changed. Another challenge for Ghana now is what we call early infant diagnosis, which is a large part of our prevention of mother-to-child transmission activities. So when a child is born to an HIV-positive mother, between 6 to 8 weeks, it's supposed to have a DNA PCR test to check whether the child is HIV positive or not. And between 18 to 24 months, he or she gets a second test, which is antibody test. And one of the things we have strengthened is this early infant diagnosis cascade. So in our sites where we work, we are able to trace mothers efficiently to ensure that they don't miss that 6 to 8 week test. We have ensured that it's properly integrated into their immunization schedule, so that they get tested. Early infant diagnosis has been strengthened. We do a lot of viral load monitoring. When the mother is on treatment, you're supposed to monitor how much viruses are still in their blood to ensure that there's viral suppression. We have supported our facilities and our beneficiaries to ensure that they are routinely monitored. I have personally supported sample transportation from the facility to actually the labs in Koforidua, where viral load samples are actually taken for processing. I have personally brought back the results and disclosed it to our mothers who are on treatment. So there's a lot of beautiful things that we have done. Strategic partnerships and alliances. We have a lot of community dialogues in the places where we work. We work with...
yes, I'll get to those issues.
That, exactly. So a lot of things have changed.
I'd like us to take the conversation step by step so we build to a crescendo.
Yes.
So you've spoken about testing as well. What... and you're not a lawyer, forgive me that I'm asking you this, but because you've been working in that environment and you've spoken about testing, but what does the law say about HIV testing? Is it compulsory? Must it be done compulsorily? Must you first have the permission of the pregnant woman before the test is done on her? What was the regime like? What does it say?
Well, I mean, technically, in most countries, testing during ANC is almost mandatory. In Ghana, it's a process we call self-selection, where mothers are offered the test, and they have an option to actually take the test or not, but you're encouraged to take the test. And I think by the time you've marketed the benefits of testing to the pregnant woman, very few mothers actually opt out of testing. Because if we test you and we know that you are HIV positive, we are able to put you immediately on antiretroviral therapy whilst you're pregnant to ensure that you don't transmit to your unborn child. So testing is very, very important. And actually, in the two sites where we work, selection was based on ANC sort of prevalence in terms of how many women are we seeing who are HIV positive.
Interesting, but again, you spoke about testing of children. Is it up to 8 weeks?
Yeah, so it's 6 to 8 weeks. It's called, it's a dry blood sample test. And when children are born, they are born with their mother's antibodies. So if you do an HIV antibody test, it's very similar to COVID-19 testing, where we have antigen tests and we have PCR tests. So the PCR is a DNA test. So if a child is reactive and has been affected because they are exposed and is already affected by HIV, you can tell through the DNA PCR test. And that test is offered to mothers as part of routine healthcare and pediatric HIV care and treatment.
I usually don't do this. When I engage my viewers, I do so usually at the tail end. But even before we started, as soon as we started, some messages started coming in. Let me go on WhatsApp, and the first message I found there, Fred Ansa, yes. Fred Ansa says, "Good evening, Moomen. I am curious. Please ask your panelists if what they are doing, especially as she says we should normalize HIV and stop stigmatizing HIV/AIDS patients, are we not then encouraging a lot more people to become careless and thereby get infected with the virus?"
Not at all. You know, I always talk about two things. There are two things that happen with HIV, stigma and discrimination. And I say stigma and discrimination is the parallel epidemic. So you have the HIV epidemic, and the second epidemic is stigma and discrimination. The stigmatizing is a belief and a perception. But if we don't address the stigma translates into action. So now someone believes about who HIV people are, and they are careless, and there are other diseases that you get through a careful way. So that, you know, because somebody asked the other person, so how did you get it? It's a better way that I could have gotten it. I got it through sex, you know. So once you talk about the fact that it's transmitted sexually, the stigma heightens. And the stigma now, if it would just remain latent, it wouldn't be concerned, but then it's acted out through discrimination. You know, and we have lots of different kinds of stigma: internal stigma, external stigma, societal stigma. And already you have someone battling with an HIV diagnosis. The last thing they need is stigma. So I believe that once we accept the fact that HIV is any other disease like diabetes, in fact, you know what? Cardiovascular diseases will actually kill more people quicker than even HIV will do. And a lot of people in Ghana have high cholesterol, and many would die from strokes and atherosclerosis, hypertension, blood pressure, before even those who are HIV positive will die. So in response to your viewers' question, we are not promoting carelessness.
Just this week, we've been having conversations about stigma generally. And again, forgive me, but these are not my words. They are the words used in many of our communities out there, that somebody is physically disabled, and the description in society is, that's the cripple's father. Forgive me, but that's the blind man's daughter. That's the madman's sister. And so when you have a sister who has a mental disorder, you do not even want to associate with that sister, because society will call you the madman's sister. Yet everybody has a problem. You extend that same argument to HIV/AIDS patients. The hospitals may have stopped stigmatizing them. But what of the communities?
Absolutely.
What has changed?
Absolutely. Yes, you know what is interesting? I mean, I have come from working in countries in Southern and Eastern Africa where the epidemic is very mature. When we say an epidemic is mature, you have prevalence rates, between 8 to 10%. You go to Botswana, 1 out of every 5 people is HIV positive in the universities. In fact, without any effort, it becomes normal. You know, so in Ghana, where we have maybe 1.69% and we have very low prevalence rates, it makes the epidemic a little immature, and there's still stigma in pockets. But I think that our behavior change is like chipping away at a very big stone. So every little effort we make is progress. So if I'm able to even address stigma among 20 people in the community, I think that's a big achievement. And how we do that is through our community dialogues. So we have quarterly dialogues where we meet assembly women, people of influence. We meet the Hairdressers Association in Ashiaman, for example. We meet the religious leaders. And then we talk about HIV. And we try to answer their questions. That helps them to, you know, dispel some of the myths and the misconceptions that fuel the stigma. because my people perish because of lack of education. It's biblical.
Yeah, I get you. But so, apart from HIV and AIDS, do you focus on any other issues, especially in respect of health, that affect mothers, but especially also children?
Yeah. So at M2M, we believe that children need to thrive rather than survive. So we support mothers through their pregnancy. But when they deliver, we also support their children and the mothers through the provision of early childhood development interventions. And the reason why this is important, I always use the example of the mother who goes to the religious herbalist to try and get pregnant and does everything the herbalist tells her. And as soon as the baby comes out, boom, you meet the baby downstairs crawling in the sand and eating and drinking water from the gutter, you know. Or you meet the baby hanging on the staircase, and probably if nobody intervenes, the baby can actually fall. So we ensure that we don't only support mothers through a journey where they can deliver HIV negative children, but once the children are born, we also ensure that they can access interventions that will nurture and nourish them and enable them to thrive rather than just merely surviving.
Like what? Education?
Yeah, so we operate, our model incorporates the nurturing care framework, which was a framework that I agreed globally at the 71st World Assembly. And we speak about 5 components, and I like to talk about 7. So these components are nutrition. We talk about early learning, early stimulation. We talk about child safety, child protection. We talk about responsive caregiving. We talk about positive discipline. So in Ghana, you find that when we talk about early childhood development, it's always about health. Oh, I've completed my children's immunizations. But children need more than health. They need good nutrition. They need a safe and nurturing environment. Yeah, they need caregivers who are responsive to them, and caregivers who discipline them positively rather than harshly, and then give them opportunities for early learning and early stimulation. So those are the things that interventions that we provide to our clients.
So I get that maybe then your focus is on the vulnerable. Is that what it is?
Yes.
Because usually we pay, and it's good that we pay attention to the vulnerable, but there are persons who we do not naturally define as people who fall within that bracket of vulnerable people. They may be well-to-do. They may be middle class. They have issues. And so the middle class person, a woman or man who is working, has a child, but the job demands that he or she leaves home at 5 a.m., returns at 10 p.m., hardly sees this kind of child. This person obviously would need some help, but doesn't fall within the bracket of vulnerable. For us, vulnerable is one who cannot feed the child very well. But if the person is not at home but has all the resources, the child will still not be fed. Do these people fall within your brackets as you bring in all these interventions?
Yes, actually, you know, we have upstream interventions and we have downstream interventions. So at the downstream level, our interventions target our vulnerable populations, and we focus entirely on the mothers that we serve. But at the upstream, we also influence policy, and policy discussions we influence. M2M is part of the ECD network Ghana. So through the ECD network, we are able to host programs that provide information to the Ghanaian population, including some of these groups that you talk about. I work very closely with Unique Curious Minds, and on Saturdays I join them in their CYB sessions, and I talk about early childhood development. And so some of that information is available through those platforms. And we also hosted a Father's Day event in partnership with African Association of Universities. You know, so they don't fall within our bracket, but we ensure that the information that they need is out there for them to support them.
All right. I got another question earlier, and I'm being very selective with my questions. Forgive me as I scroll to get it. So, yes, this one from Eric Boama says, good evening, Moomen. Your show is one of the best shows. You always speak to issues, the issues that are not sensational, but very realistic to our survival as a people. Great. Thank you very much for your endorsement there. Now, you say, many of these NGOs have very brilliant ideas, but when they come, they work in Accra, or even where they choose to go to other parts of the country, they end up focusing only on a few communities. Now, she talks about nutrition and other factors affecting early childhood development. The places that need their interventions most are in the very interior parts of the country. Have they reached out to some of these communities?
Thank you. So we believe in a phased approach, and in Ghana we have an investment case. Learning, start small, learn lessons and expand. So in our investment case we have plans to actually reach out to some of these communities, and already we are working in Ashiaman. Ashiaman is one of the most congested populations in Ghana, and in Ashiaman you have a number of villages that have actually combined and available. Even though they are in Greater Accra, they have a lot of semblance to some of these rural populations. In Atwa, we work with Lower Manya Krobo district, where HIV has had a long history. So yes, there are plans to go where the need is, and the selection of the sites actually were done very closely with Ghana Health Services, and it was very needs-based and needs-driven, emphasis on high HIV burden. So you might find, for example, in the north, where there are places in the north where you have very compromised indicators for maternal and child health, but HIV transmission is very low. You know, so we need to combine. If you go to places like maybe in Brahafo now, we're beginning to see a surge in HIV cases. You go to Ashanti region, there's a surge in it. There's now a new surge. So there are new regions that are beginning to come up where the need has shown that there's a demand for services. So the choice of the sites is based on all of these factors to ensure that we add the most value where the need is available.
So let's pick the items, if we can, one by one. Nutrition.
Yeah.
What are you?
Oh, nutrition is very interesting. So in nutrition, we have what we call parenting information playgroups, where we teach mothers on what good nutrition is. We're actually starting a new project, an intervention called High Interval Intensity Service Provision in Nutrition, where we teach mothers. You know what is interesting? I was saying to someone that a mother in Ghana, the emphasis is on Mebano Wamin, is my child full? It's not on, is the food that I'm giving to the child nutritious to this child? So those are some of the education sessions that we provide to mothers at when they come to the facility, when they're in the support groups, and also at the community level. Yes.
Okay. You also spoke about, and I didn't get that, stimulation?
Early stimulation. So we talk about the fact that when we talk about early childhood development, we talk about the first 1,000 days, and it starts from conception to birth. So as soon as you know you're pregnant, stimulation starts from there. And mothers are taught to sing to their unborn children. Mothers are taught to read to their fetus. And it will surprise you that those interactions and bonds are actually created right from the womb. Yeah, so that's early stimulation. And then, of course, we have early learning.
You read to an unborn fetus?
Yes, you sing to them. You can see that when you're singing, they're actually moving their legs, when they can move, when they can shake.
You don't sing?
Absolutely, absolutely.
Scientifically proven, or you just have a
scientifically,
and women have testified to this, that they sing to the unborn baby,
absolutely,
and the unborn baby responds.
Yes. So when the baby is born, it already has an interaction and a relationship with the mother. And even fathers. I mean, there are fathers who have put, radio devices on their wives' bellies and played. And there's conditioning. As soon as you put the radio there, the child knows that maybe it's time to feed, and mommy is going to eat, and I'm going to have something, so the baby can actually start kicking. So it is very, very important. So what we are saying is, early childhood development does not start after birth. It starts at conception.
Wow. I'm surprised.
I know.
An unborn baby. Okay, so you mentioned other factors. You mentioned them so much. I mean, in
So
succession.
quickly.
So I couldn't note everything down. I recall you also spoke about discipline.
Yes. So we emphasize positive discipline. You know, I mean, I always say that the harsh discipline that we are akin to in Ghana sometimes actually affects how our children turn out. You know, discipline comes from the Latin word to disciple, to teach. So at M2M, we focus on positive, sensitive discipline rather than harsh and negative discipline.
You quoted scripture here. The scripture also says,
Spare the rod for the child. Yeah, yeah. I know that Ghana is hinged on that, and sparing the rod and spoiling the child can take many forms. When you want to spare the rod, when you want to use the rod, it could actually mean taking him away from his favorite TV station. It could actually mean you can't go and visit your friends this weekend. Withdrawing the positive reinforcement from the child. That is another way of using a rod. It doesn't mean that you need to calm down. And what I stress with parents is, I always look at a mother who is 35 years, and you have this 3-year-old infant that you're actually coming down very strongly on, but you guys are 8 years apart. And you know, I tell my mothers, the child knows that you're in charge. You don't need to prove yourself to the child by beating the child so hardly. You know, and it destroys all efforts of the child to achieve independence and to build emotional connections. Harsh discipline. It teaches the child that violence is the only way out. So those are the children you see in schools biting people, hitting people, and you know, having challenges,
that's true.
building friendships. It's very, very true. Yeah, because children model what they see. So if you keep beating your child at home, that is the behavior that she thinks mommy says is right.
See, at M2M, one of your focal points is to ensure that there's a healthy generation. The next generation is healthy. But again, because you spoke about the mental mothers, persons living with HIV who may become pregnant and who may need some guidance and counseling. This is done by persons who already were living with HIV and AIDS. So in respect of transmission from mothers to children, what picture can you paint for us? What does it look like?
I mean, you know, in our sites, mother to child transmission is as low as maybe 1.09. So the UNA's benchmark for effective elimination of mother to child transmission is about 5% in the cohort that is receiving treatment. In our M2M sites globally, we've achieved near elimination just through this support. And so in some of our sites, we've achieved maybe 0.89%. In our sites in Ghana, we've achieved 1.09%, whereas in the other sites in Ghana where our services are not available, transmission is as high as 8% or 10%. The second thing in relation to that is in terms of even pediatric, the few children who were found HIV positive, 89% of them are already on treatment. But in the rest of Ghana, some of the data shows that only 26% of these children actually get initiated. So the picture is the fact that psychosocial support is a very integral part of addressing transmission to unborn children. Mothers who are pregnant and HIV positive need to have hand-holding from day 1 to month 9 when they deliver and after they deliver.
For the few children who may be living with HIV and AIDS, and these days when you walk around major cities in Ghana, I mean, after every 3 or 4 buildings, you're likely to find somebody having converted his house into an early Childhood Development Center. We find them everywhere. And my personal experience, sometimes you go to some of these so-called early childhood development centers. They're just schools that people have opened, whether properly registered or not, in every community. They take in the children, employ persons who do not have any training. You are aware of this. Does it worry you? What can be done to rectify the situation?
I'm aware of it, and I'm actually not terribly worried, even though there's concern, because the standards exist with the Department of Children in the Ministry of Gender, Children and Social Protection. So they have social welfare officers that actually are charged with the mandate. So there is a system in place, and there's a structure in place to actually inspect these sites and avoid the mushrooming. I think the challenge we have is ensuring that they are effective and accountable. Because maybe I should retract my step and say I am worried that children actually find themselves in those situations. But I'm also comforted that the standards exist and the mechanisms are there for us to be able to control it. So it's a question of accountability. Because everywhere you pass, you see a nursery. Everywhere you pass, you see a harsh environment where children are being put. But we have a ministry that is actually charged with addressing the quality and the standards of such institutions.
You speak to officials of the social welfare department, and the biggest challenge they have is that of funding. So on paper, they have the mandate to go around and ensure that standards are met. But in reality, they do not even have money for transportation. The vehicles are not available. Where they have a vehicle, they don't have the fuel.
Exactly. So that's why as M2M, we are part of the Early Childhood Network Ghana, which is a platform and a network of ECD practitioners. And so this network actually brings together the ECD practitioners who are officially registered, and through their support they are able to provide feedback on some of these mushrooming ECD centers, and where the centers actually need support and need TA, we can actually provide that kind of support to them. I think that it's a very worrying situation, and it has become a money-making business, because everybody knows that mothers will always give birth, and mothers will need to go to work. So let me just, get a 2-room and turn it into a creche, or turn it into a Montessori center with no Montessori trained teachers, for example. So I believe that it's a collective responsibility to hold ourselves accountable. Especially, we owe it to our children to ensure that where they study and where they have their early experiences, they are not harsh environments, and they're able to access the nurturing that they need.
So far, we have focused our conversation on mothers, the mentor mothers. We've focused on the children, but those between childhood and motherhood, the adolescents. That's a critical age where sometimes parents neglect them because they feel they have come of age. Sometimes the adolescents themselves seek independence because they feel they have come of age when they have not indeed. And then it is also an age where there appears to be a lot of confusion, internal conflicts within the adolescents themselves. When it comes to adolescents, do you focus only on girls?
No, actually, these days we speak to adolescent girls and young women, and we speak to adolescent boys and young men. In our immediate project portfolio, we focus on the adolescent pregnant mom and also the adolescent postnatal mom. But of course, the adolescents have partners, and they have male partners, they have siblings. So we implement a family-centered approach. So even though the adolescent young girl will be the entry-level client, when we go to the house to support this adolescent girl, there are other persons in the home who will benefit from our education. And that will include the adolescent young man or the adolescent male or the significant other of this adolescent young girl. So even though our entry point, our index client is the adolescent girl and young woman. Our indirect beneficiary is the male. So we focus on both sexes.
So you've told us about when it came to children, nutrition, discipline, there was stimulation. What do you focus on when you turn your attention on adolescents?
You know, like you said, adolescents are a unique group. Adolescents are, you know, they're going through a period of rapid growth. There's a lot of confusion. Adolescents tend to be very rebellious. They live in the present. They are not afraid of the future, you know. So a lot of our work actually focuses on adolescent health and well-being, and ensuring that adolescents have the right skills, the right knowledge, the right attitudes to achieve health and to achieve the health outcomes that will not compromise their current health as well as their future health. I always say that adolescents are our future population, so investing in their health is also investing in the future health of the nation. These are young leaders, and these are our next group of our leaders and our pace setters. So in our programs, yes, we focus on health, we focus on education, but most importantly, we focus on differentiated services that are friendly to adolescents. So we talk about differentiated adolescent health services.
Which I don't understand.
So when you talk about differentiated services, you talk about services that are designed with the adolescent in mind, where the services are conducted, who provide the service, what is provided in that service. Is it friendly to the adolescent? So for example, if you have an HIV positive adolescent, we would rather they come to their own clinic and come for their own refills at a specified time rather than joining the larger pool of older women 25 to 49. So our adolescent population focuses on the 15 to 24 young moms. Exactly.
Young moms. You encourage adolescents to become moms?
The opposite. When the adolescent finds themselves as a young mom, we did not discriminate against them, and we did not leave them alone. In fact, that's the time that they need us the most.
What's your position on abortion?
I'm a Christian, so I actually don't support abortion, and I will not be able to speak on behalf of M2M's position on abortion. Yeah.
I respect that,
yes,
because
yeah.
I really wanted, but I respect that. I won't go any further because that's personal, and you do not want to speak on behalf of M2M in respect of this matter. No problem. But again, so still talking about adolescents and the issues that are peculiar to them. But I also realized that when we began the conversation, again, we spoke about the mental mothers. It's something that I am so very interested in, because for me, it will serve the purpose of not just destigmatizing HIV and AIDS, but it will also ensure that persons who would ordinarily have run away from seeking medical attention will now make themselves available to receive that attention, which is a very good thing.
Yes.
But adolescents, so what's the message? That they should stay away? If you ask them to stay away, are we being realistic? Because adolescents are having sex. Can you stop them from having sex? If you can't stop them from having sex, are you going to tell them then go ahead and do it because we have mental mothers in case you get pregnant, and in case you are infected, we have people who can mentor you? What's the message?
You know, our model is a life cycle model, so it starts from conception right through birth to adolescence. And so we are very, very aware of the challenges that adolescents face, and our role is actually to support them navigate this very confusing era in their lives. So you know how we do that? Actually, because our model is peer-based, for our adolescent program, we also have adolescent peer mentors who are 15 to 24, who are young HIV positive moms at 15 to 24. I have just finished training a few in the last, actually I'm in the process of training 4 in my office. And so they can also share what they have gone through and provide the best source of counseling, saying this is what it is and this is how it ends, and this is the support that is available. So the prevention model is abstinence, being faithful, or condoms. So the first thing you emphasize is abstinence. If you cannot stay away from sex, then you need to be faithful to one partner and not have multiple partnerships, because that is what compromises your risk. If you need to have sex, then you should use condoms. So the global framework for prevention is ABC, abstinence, being faithful, and condom use. But that is usually among married and consenting adults, you know. But unfortunately, you will find that adolescence is a period of risky behavior. So we even talk about nutrition, because nutrition is very important.
Right.
Should the adolescent become pregnant, then they would have sufficient nutrition stores that will not compromise the health of the unborn child also. You know, so at M2M we are not encouraging reckless sexual behavior, but we also recognize that we can support adolescents to be resilient, we can support adolescents to be knowledgeable, we can support adolescents to be involved in their health-seeking behavior.
Oh, so I was just reading through some of the things that you've done so far, and I'm very impressed. Not just in Ghana, but like you said, in Southern Africa,
yes.
you've done. Are you achieving results collectively on the African continent? Because what happens, and coronavirus has shown us that no country is an island, and we're beginning to wrap up now.
Okay. No, I think that I'm very proud to be associated with M2M. We have a unique model. It's a simple, effective model that focuses on one vital resource in our communities, and that's mothers. And you know, when you put mothers at the helm of things, you see change. So the model is transformational, and we've seen results. Working in the 10 countries, across the 10 countries, working with mentor mothers, we have seen a lot of changes and a lot of outcomes, even in the treatment journeys of the mothers that we serve. But beyond that, we have also influenced governments, you know, to be able to take on some of the lessons that we have learned and to implement some of the best practices that we have seen. You know, so I am very proud of the work that we've done in those 10 countries.
Yvonne, before we go, in all of this, the mentor mothers, women, and most of the care we've spoken about in respect of nutrition, the discipline, even your references were mostly to men, women. When it came to adolescents, I said, well, the boys can benefit, but our focus is on the girls. What role do men have to play in all of this, in the work that you're doing? How do men come into the picture?
Oh, we are very focused on male involvement and partner involvement. So we offer, for example, if a mother tests positive, we encourage the mother to actually bring the husband for the male partner to be tested. The men actually are invited to our parenting information play groups, you know. So we have a conscious and intentional plan to ensure that males and partners and fathers are part of their children's development. In fact, for a woman to be successful on treatment, she needs the support of a husband.
So when a woman goes to meet the mentor mothers, for example, she comes with the husband. Do men follow their
yes,
in Ghana? Have you seen that? Have you
yes, they
experienced
do.
that?
And actually in Ghana, if you come with your husband to the antenatal clinic, you are served first. There's an incentive for male partners coming along with their wives.
You spoke about the ABC, abstinence, being faithful, and then condom use.
Yes.
Condom use. People want to use condom, but buying condom is one of the most difficult things to do. Sorry that I'm laughing, but it's a joke. It's a joke that somebody goes into a pharmacy and decides that regardless of how many people come after him, he will wait until they are all served before he buys a condom,
because there's shyness about it.
Yes.
So they're shy to even procure the condoms even though it's free.
And so if I have to waste 30 minutes to buy a condom, I better leave it and go and attend to my business the way I should. How do we make accessing condoms much easier without all the negative, connotations attached to it?
Yeah, I think that one aspect of the work that we do, which we emphasize, is confidentiality too. I mean, if people want to be able, because there are social marketing strategies, and for those NGOs like DKT, like Planned Parenthood, who have a mandate to actually provide direct services. M2M does not provide direct services around condoms, but we provide the education around condoms, not just for safer sex, but also for family planning. Because that's the second prong in our PMTCT model, is to ensure that we prevent unwanted pregnancies amongst our populations. So you're right, condoms, now even in Ghana, there's actually a shortage of condoms, even around in NACP. So I think that addressing stockouts of commodities, including condoms, is something that we need to harness more energy around.
I have a few in my car boot. The Ghana AIDS Commission gave me 140 pieces of condoms. They are still very intact in my car.
Do you count them every evening to make sure?
They're still packed the way it was given to me. And so if you need some, you can contact me for those who want to get busy. I'm ready to donate some of mine.
You have 140, so we will be sending our young people saying that, Mr. Moomen has some condoms in his car, and would you like to contact him?
Yvonne.
Thank you.
Thank you so much. This is an ongoing conversation.
Yes.
You have promised to get us
my mentor mothers.
The mentor mothers.
Absolutely.
I look forward to that conversation.
Absolutely. I think Ghana needs
that.
Next week
or two.
Absolutely. You have it.
Thank you very much.
And I'm very happy to honor my promise.
Yvonne Prempe Ferguson is the Technical Director, Mothers to Mothers, for short M2M, which has been talking to us on a range of issues, but particularly on early childhood to adolescence, the vital steps in between. She's told us how the Mothers to Mothers have been able to come up with this very innovative idea and they're actually implementing it, where you have persons living with HIV who are mothers advising others who are about to become mothers. So as a result of that, they're helping to reduce the stigma, but also encouraging a lot more persons living with HIV to access health care and so on. We are very grateful to you, but we look forward to speaking to those women and yourself so we can move the conversation forward some more. Thank you very much.
Thank you very much. It was my pleasure. And thank you for having me.
Thank you.
Thank you.
And thanks for being a part of the show. News comes up at 10. Please don't go away. This is GBC News. Have a good night if you're going to bed right now. Bye-bye. Speak on Moomen Tonight.
By some of your appointments, you appear to be creating a parallel civil service.
2020 is not too far away from today. Are we seeing a comeback?
Would you say that HIPIC truly served any purpose?
The debt overhang on the